Natasha Trent-Costa from Cedars-Sinai. So we're privileged to have her be our moderator for this next session as she brings a unique sort of knowledge base for sports medicine, as she has a pediatric and adult sports orthopedic surgery background. So she trained in Santa Monica Orthopedic Group in her adult sports orthopedic surgery fellowship, where she worked at the LA Galaxy and the U.S. national soccer team, and then went on to get her pediatric orthopedic surgery subspecialty fellowship at Boston Children's Hospital. She's now at Cedars-Sinai, where she does a lot of research focusing on pediatric athletes and female athletes as well. So I'd like to welcome up Dr. Trent-Costa.
Dr. T works too with most patients. Thank you, Dr. Chen, and thank you for organizing with Dr. Little a wonderful program this weekend. So we're going to look at innovations in sports medicine, and compared to sort of what we were seeing earlier this morning, a lot of ours is not focused on as much the technology, but as into regenerative medicine and orthobiologics. So let's jump right in and get back on time. So we have Dr. Jonathan Koenig here, who's a friend and colleague and fellow New Yorker, who also does a lot of pediatric and adult sports medicine here in LA on the west side with me, as well as at Shriners LA. And he's here to talk about a very popular topic in sports medicine, ACL repair.
Thank you, Natasha. Thanks to the COA. ACL repair is somewhat of a taboo concept, but I think it's coming back, at least in some parts of a sports medicine practice. And I think it's important to kind of look back at history, like our future president of the association said. I was also a history major in college, so I do like looking at the past to kind of revisit the future. I know when I was only a resident less than 10 years ago, the only rule about ACL repair was you do not talk about ACL repair. That conversation has drastically shifted. So before we jump in the DeLorean, we'll take a look at kind of how long this has been going around. ACL repair first reported back in 1895, but this was a very, very different surgery. This was an open arthrotomy. This was tying sutures into the ligament, tying it back over the IT band, putting the patient back into some form of closed immobilization for weeks on end, crappy rehab, and the results, as we learned, not so great. This was kind of a landmark study from the Journal of Sports Medicine in 1976. Basically, the conclusion, 94% still had instability, 53% would re-injure their knees, 38% went on to get extra procedures. This was a large military cohort, so guys who needed their knees. And the conclusion then, this was their statement, is doubtful that this surgery will ever be useful. So ACL reconstruction started to become popular, but one landmark study also came out right around 1991. This is the Sherman classification that everyone who does ACL repair should now be able to cite and know. But what was important about this study is at the time it kind of looked back at other people who were performing ACL repairs, and it said, maybe they're not all so bad. Let's see which ones actually do okay. And so when they created this subclassification system, these proximal avulsion, the ACL tears where the ACL actually ripped off of the bone, those actually did pretty well. Even the second classification, which was not a complete avulsion, but maybe about only 20% of the remnant ligament was still attached to the bone, those did pretty well too. It was more those mid-substance tears that did terrible. However, by that time, this paper came out, ACL reconstruction, rocket ship had taken off, and ACL reconstruction became the gold standard, which is not so bad. ACL reconstruction is a great procedure. It's, after joints, it's probably the third or fourth or fifth most common orthopedic surgery performed. We've got great results. We do very well. And if anything, this is a report out of New York State that's just showing that, especially in my specialty of adolescent pediatric sports medicine, ACL tears and ACL reconstruction is skyrocketing over the last 2 decades. So we're doing a lot more of them, and it's a great surgery. That's very good, right? But it's not perfect. And so we want to make all our procedures perfect. You know, anyone who does ACLs, we know that there's plenty of donor site morbidity. If you've done a BTB or you have a friend, and anyone in the audience who's had their ACL done, and they had a BTB, they know that that knee pain lasts for a while, that anterior knee pain. ACL reconstructions, not so great for that natural proprioception. There's lengthy rehab. There are certain populations that still have high failure rates. You know, if you've ever done a revision ACL, you know that really sucks. That is not a fun procedure. Return to sport still kind of diminishes over time. And then the other thing is, even the most perfectly done ACL reconstruction, you're still likely going to go on to osteoarthritis. It's still going to happen. So, you know, why not revisit that information that kind of got overshadowed in the late 90s? And then we had a bunch of other advancements that have come out since. And there was sort of this renaissance, so to speak, of revisiting ACL repairs that maybe wouldn't be so bad. You know, arthroscopy has gotten better. Our tools, our instruments, our suture anchors, everything that we use in arthroscopy has improved. We can do things a lot sleeker, a lot sexier, a lot less invasive. As we'll talk about afterwards, there are a lot more biologic augments to our procedures as well. And also our imaging technology, our prediction, our ability to know what we're going to see inside the knee before we get in there. So I revisit that Sherman classification, right? We bring that back. We know that there are certain cohort of ACL tears that may be amenable to ACL repair. Augment that with a much prettier picture than the Mona Lisa, this vascular study of the ACL. We know that a real high concentration of the blood supply to the ACL is in that proximal area. So if we have a tear that's not in the mid-substance, down where that arrow is, but more concentrated closer to the bone, maybe these will heal better. So kind of the most published author on ACL repair, hashtag Save the ACL, is a mentor of both Dr. Trent Acosta and mine, Dr. DeFelice back in New York. He's published the most, but I'll quote a few of his studies. You know, he seems to think if we look back at Sherman, look back at some other epidemiology studies, that those proximal tears happen sometimes 40–50% of the time. I mean, I would argue anecdotally, I don't think it's that high, but it's definitely more than 20–30%. It might be like a third of the time we get in the knee, and we have two different pictures. So you get an MRI, someone's unstable, they want to get back to sports, you make the decision to have surgery, you put the camera inside the knee. These are both patients have an ACL tear, but everyone can see these are two very different pictures, right? The knee on the left, that ACL kind of looks good. It still looks like it's intact. It still has that synovial sheath overlying it, and it's just ripped off the bone. You know, maybe we can treat that differently than the torn mop on the other side, which is kind of like tying a whole bunch of ponytail hairs back together. So that's where, if we don't take this stance that all ACLs can be repaired or all ACLs need to be reconstructed, and we start kind of revisiting ACL repair, but in a more nuanced way, that's where I think we're going to start to see some success. So you take that ACL tear on the left, and you do a repair, right? You're able to get some good suture fixation, use our new suture anchors, reattach it back to the knee, but don't forget reconstruction. Sometimes you just got to cut it all out and rebuild. So this is kind of a picture that's my preferred technique. This has been published lots of times. Basically, we're using kind of suture passers, whether it's a scorpion or first pass or suture lasso to pass suture through your remnant stump of your ACL. Then you do some sort of notchplasty, some sort of microfracture to increase your healing, and you'll take a suture anchor, you'll put it into the lateral wall in the notch, and then you'll back it up with some sort of internal brace. And I think there's plenty of data now coming out that this is a good technique. There are other described techniques as well, but this is my preferred and probably the most commonly performed. And we're starting to get some results over the last 10 years. For the most part, I would say the results that you read, depending on how you interpret it, they're still not as great as reconstruction. But overall, we're getting lots of things like there's less pain with an ACL repair. There's a faster recovery. There's obviously less drilling. You're not drilling 9–10 millimeter tunnels. You're restoring natural anatomy, so the proprioception's better than a reconstruction. no donor site pain, which often leads to a much better what they call a forgotten joint score, where you don't remember which knee had surgery. And then the best story is you say no bridges are burned. If an ACL repair fails, you didn't already perform a reconstruction. There isn't a 10-millimeter tunnel in the femur that you got to watch out for. You can revisit an ACL reconstruction. So we're starting to see and figure out which patients will benefit from ACL repair. Some meta-analyses really just showing like really good results, really great outcomes, especially when you're selective with those Sherman 1s and 2s, right? The ACLs that really stay intact but kind of avulsed off the bone as opposed to shred into a million pieces. Unfortunately, we don't have any like great randomized blinded trials where we didn't tell the patient what we did to their knee, so we do need some higher quality data. I do want to say, especially in my subspecialty, younger patients tend to not do as well with ACL repairs. This is kind of the only one big study out of Denver that showed a really high failure rate in his repairs at 3 years. And so this is kind of a little bit of the dogma in pediatrics, is we're still trying not to do ACL repairs in this high-risk population. But then comes along this other new fun technology called the Bayer implant, if everyone's heard about it. It is this bovine collagen implant. It's about the same size and shape as a wine cork. I think everyone can relate to that. And basically you suture it in between the torn end of the ACL and the bone. And it's meant to kind of expand from those ACLs that have really completely avulsed off the bone, but maybe those Sherman 2s and 3s, the ones where the tear is a little bit lower, the collagen fibers are still intact, and you want to try and repair it. This has been coming out of Boston Children's Hospital with Martha Murray. There have been plenty of data. There's comparison trials where they've done 100 Bayer, 100 autograft ACLs, and saying that roughly equivalent, or what I love the word they like to use, non-inferiority. But again, no bridges burned. They've done MRI follow-ups. They've done everything. But all of the data thus far with Bayer, which has really only been released to the mass market for about 4 years, is really out of Boston. The Bayer Moon trial, which is a multi-networks trial, that's currently ongoing, and we'll see more data on this ACL repair technique with years to come. So bringing it home, last concept I want to know, anyone who does a lot of knee surgery has heard of these lateral extra-articular procedures that have gotten popular in sports medicine. Basically, it is a way to augment knee stability by fixing or tightening some of the lateral structures of the knee. There are two real buckets of it, whether you're doing kind of like an IT band reconstruction, or sometimes an free allograft reconstruction, and ALL reconstruction. This paper from 2020 from AOSSM, this was like the winner of all research done, and it's really blown up lateral extra-articular procedures in knee surgery. It really does improve laxity, improves stability, improves patients returning to cutting sports, and it reduces the failure rate of ACLs. And so a lot of people, myself included, are already starting to introduce these lateral extra-articular procedures to their ACLs. For me, I pretty much only do it in a revision setting or in someone who I really have a lot of worry about and I think is going to fail, whether that's a lot of hyperextension at the knee, EDS or hypermobility, or something where I really want to make that knee as stable as possible, or maybe they have some coronal or sagittal deformity that we're not going to correct. We will augment their ACL with this lateral extra-articular procedure. So high risk and revision is what I'll summarize that for. But now here's my question. Why not do both? Why not start adding this new procedure, these lateral extra-articular procedures, with an ACL repair and see if that combination starts to improve our ACL repair outcomes as well? So this first paper, published only 5 years ago, was a surgical technique paper. And it's really showing that if we are, and their outcomes were generally great. They followed some of their patients for 2 to 3 years and showed, really great outcomes. Three papers have been published in the last 5 years on this topic, really small cohorts, but generally showing positive results. So again, statistically no difference. They're showing these retro cohorts. You add a lateral extra-articular procedure to an ACL repair, really great outcomes. This is kind of a diagram that was kind of published in one of those last papers that I pretty much now follow myself. You get an ACL rupture. You can often predict on the MRI, never with 100% certainty, but you can get a good idea, is this a complete mid-substance tear or is this an avulsion type tear? And then you kind of go into the OR with a plan. You say, no, we're just going to cut that out and fix it, or we're going to try and repair it and maybe augment that ACL repair with some sort of lateral extra-articular procedure. In my hands, what I will do is, I showed you that picture of kind of suturing the ACL stump. If I think I can repair an ACL, I will pass suture into it, and I will literally pull the knee off of the operating room table with those suture tapes. And if they rip out of that stump, okay, you can't repair it. Cut it all out, move on with the reconstruction. If those sutures are holding, I'm going to try and go ahead with an ACL repair. So in summary for me, if we're being very selective, and I didn't talk a lot about what those criteria were, but a lot of them are, again, under 18, try to avoid an ACL repair, or maybe let's just say you're done with college athletics, you can try an ACL repair. The acuity of the injury, there's some data that shows you want to try and do these ACL repairs within 5 weeks of the injury. They're stretching that 5 weeks more and more now, but right now that's kind of like the sweet spot that we're saying. Again, the tissue quality or tear pattern, which you won't 100% know until you're in the knee. And then also patient demand. If you have a high-level athlete, maybe an ACL repair, which still has lesser outcomes, is not good for them. You check your MRI, you have a conversation with your patient about, the outcomes of each, and just be prepared for both. But for now, I think reconstruction is still king. That is what we will continue to do for the most part in ACL reconstruction and repair. So thanks, guys.
Thank you, Dr. Koenig. Next up, we have Dr. Parsa here. She is a native Californian who trained here as well as in Chicago and under Dr. James Andrews as well. And she has a robust practice down in the South Bay and with a particular focus also on using orthobiologics. So she's here to talk about orthobiologics in operative sports medicine.
Thank you, Natasha and the COA. Some disclosures. Today I'm going to be discussing some of the history of orthobiologics, as well as some of the relevant applications in orthopedic surgery. We have maximized mechanical repair techniques, and now we can make the most impact on our patient outcomes by focusing on and understanding the biology. Although orthobiologics is viewed as novel or innovative technology, it has actually been around for a long time. We know fractures may not heal either due to mechanical failure or biologic failure, or both. Numerous studies have proven that autologous cell injections can improve fracture healing in the face of non-unions. Carnegie showed a dose-related response where he noted that callus formation directly correlated with CFU counts and treatment effects. Looking at some of the challenging problems in orthopedic surgeries include cartilage lesions and OCD lesions. Gobi et al. Had published multiple studies looking at collagen and hyaluronic acid-based scaffolds augmented with BMAC and found better results maintaining over 5 years. Multiple studies have also showed improved outcomes of microfracture, osteochondral allografts, and ACI with BMAC augmentation. Orthobiologics has shown to modify the natural disease progression of arthritis. This study looked at treating bone marrow edema lesions with BMAC and DBM combination. They found a statistically significant improvement of pain reduction scores, pain scores and functional improvement in the IKDC scores. They also noted 75% improvement of these bone marrow edema lesions on MRI follow-up at 2 years. This study, treating with these bone marrow lesions with subchondroplasty, looked at 70 patients with moderate to severe OA. They found that the KOOS scores improved over a 2-year period in all categories, including activities of daily living, including pain, symptoms, and quality of life. Over 75% of these patients remained free from total knee conversion at the 2-year follow-up. Hernigue et al. Published a longer-term study where they treated osteonecrosis of the knee with a BMAC iliac injection, 40 cc subchondral injection, and they found that there was improvement of these lesions at 10-year follow-up, as well as maintenance of joint space. Even in cases of meniscectomy, where we can expect advancement of arthritis, this double-blinded randomized control trial published in JBJS showed that a single injection of allogeneic mesenchymal cells helped mitigate volume loss and improve pain scores through 2 years of postoperative follow-up. The meniscus is elegantly complex, and it is one of the most commonly injured. Some of the challenges we face with repairs, including the relative avascular and acellular nature, which limits healing. Our meniscectomies lead to increased risk of osteoarthritis, and we know that the location, the tear pattern, and geometry often pose a risk. But with the improvements in orthobiologics, we have now moved to the motto, #SaveTheMeniscus. Some of the sources have reported different techniques to improve biology of the meniscus with repairing it, including rasping and trephination, marrow stimulation, external fibrin clot usage at the site of the repair, PRP or cell-based therapies to promote healing, and biomaterial augmentation, like scaffolds to enhance the repair integrity. This was a great recently published review applying biologics to a hypovascular meniscus to improve the repair results. Their goals showed improvement of cell incorporation, vascularization, matrix deposition, and inflammation relief. Moving on to the shoulder. Orthobiologics has a role in treatment of partial rotator cuff tears that we don't typically repair. This study looked at 24 patients comparing BMAC PRP injections versus 3 months of physical therapy. Although they found no difference at the 3-week mark, they noted a statistically significant improvement in VAS scores and ASES function scores at 3 months. This study, published by Hernigue, looked at BMAC in the face of a rotator cuff repair. They noted enhanced healing rates, improved radiologic quality of the repair surface, and decreased risk of re-rupture compared to the controls. Now we have more randomized control trials, published reviews, and real-world evidence showing that these mesenchymal stem cell injections can improve healing and prevent further re-tears. This is important as still to this day, with all the advances in repair techniques and materials, there is still a 20 to 25% or even higher re-tear rate reported in the literature, or what I like to think of as the rotator cuff non-union. Therefore, the current treatments of rotator cuff repairs are suboptimal. There is a significant need for disease-modifying therapies. Looking at the advancing use of biologics, we can tap into the different sources of MSCs that are available and easily accessible. This includes adipose therapies. This review of the literature looked at a total of 18 studies. 10 of them were using adipose therapies. Three of those were randomized control trials, and they found substantial positive results in 8 out of 10 of those studies, with improvement of pain and function scores. They propose the mechanism is a paracrine effect that has a suppressive effect on pro-inflammatory cytokines, as well as enhanced tissue remodeling and angiogenesis. The preclinical studies in animal models show reduced inflammation and improved tendon healing and strength. However, in human trials, we are still seeing mixed results, and they conclude that we still need further studies. So why is there so much variability in the literature? Variability often has to do with the patient themselves. This presentation out of AUKUS in 2021 reviewed over 140,000 patients, and they found that the strongest predictor of complications was nutritional status. More and more studies are showing that amino acids go beyond just being the building blocks of tissue, but they also play a vital role in cellular signaling pathways for the enhancement of muscle protein synthesis, bone mineral density to improve fracture healing, collagen synthesis in wound healing, and MSC differentiation. These can be targeted to upregulate the pathways of interest. One of the biggest concerns of injuries and surgery is the subsequent muscle atrophy. This study shows the important role of protein and amino acid supplementation in the activation and increased proliferation of muscle progenitor cells known as satellite cells. These cells are responsible for muscle repair, angiogenesis, and improved innervation of muscle tissue. The reason why there is such a value in supplementation of amino acids as an adjunct to orthobiologics is that they're involved in common overlapping pathways, including improved anabolic pathways, decreased catabolic stresses, improved collagen synthesis and angiogenesis, and improved cellular energy and repair. Therefore, in my practice, I'm harnessing all of these modalities and optimizing my patients in perioperative and periprocedural periods with amino acid supplementation to influence improved healing and of the treatment areas. Although I do not have any financial disclosures to report on this slide, I'm currently working on a study with this company to understand if amino acid supplementation can further improve the PRP product when combined with short-term exercise. This was a study that I co-authored during my fellowship at the Andrews Institute. Lastly, the potential complications is why the US is still concerned. Centeno et al. Had published a multi-center analysis of over 2,000 patients. They reported 300 adverse effects, but a majority of those were pain related to the injection or pain related to progression of osteoarthritis. They did note 7 neoplasms, however, they did state that this was lower than the general population. Berkowitz did report a case of a glial proliferation lesion in the spinal cord after intrathecal injection of embryonic cells after a stroke. Therefore, in my practice, I try to stay in the middle ground where I support the use of autologous cells as they are safer than allogeneic. The risk of tumor genicity is the reason why higher levels of investigation are warranted before we can appropriately delineate safe treatment protocols involving cell culturing and expansion of cell lineages to therapeutic dosages. In summary, now that we have maximized the mechanical side of sports surgery, we can make the greatest impact on outcomes through biology. Thank you. This is a little shout out to the National Shoulder and Elbow Week coming up, 12th through 17th. There is a event in Los Angeles Friday night. If you guys are around, you can find more information on the website. Thanks.
Thank you, Dr. Parsa. And let's see. Next up, we have Dr. Sharon Haim, who is also on the west side. She is a professor at UCLA, taking care of multiple UCLA sports teams as well as USA basketball. She's a former president of RJOS, as well as the Forum, which is a female sports medicine society that we have here. And she'll be talking on innovations and augmentations that we're seeing in shoulder surgery these days.
Thank you so much. It's such a pleasure to be here this morning. Again, I'm going to be talking about shoulder surgery in particular, some of the things that, and here are my disclosures. As an introduction, I'm going to be talking a little bit about the diagnostics and AI, shoulder instability, and then what we do in rotator cuffs. We all know that we have significant failures still in both of these types of surgeries, so we really need to really continue to innovate through our diagnostics and prevent these failures. So just looking a little bit about AI in shoulder surgery. In shoulder surgery, we're really a little bit behind other joints when looking at AI, but how can we use this in the shoulder now? Well, certainly we can predict complications, we can look at outcomes, we can predict costs, and we can do image analysis, which is great. And this is a nice article. If you want to look at some of the things that are being done in shoulder surgery, you can take a look at that. What was most interesting to me as I looked at this is really what are we doing for our patients in imaging and how fast can we get them done? This is a recent study just done a couple months ago looking at arthroscopy compared to a 7-minute shoulder MRI using parallel imaging, meaning looking at all planes at once. This is a deep learning super resolution 3T MRI. And very exciting, we have good results there. UCLA Radiology has now introduced Deep Resolve into several of their locations. We can do a shoulder MRI now in 5 to 6 minutes. So you can imagine what that does for your patients, particularly the ones who have claustrophobia. You get high resolution. This is an example of one of the ones done at UCLA. And the downside of this is very expensive to install. So it takes some money to get this in there. But again, some of the advantages in our AI and imaging. So the things that I'm going to be talking about today, particularly with instability, there are many aspects that we can look at in innovation. I wanted to talk a little bit about the solid versus all suture anchors and knot versus knotless. I think there's some innovations, and over time I've changed my practice as these have developed over time. So if you look at a solid anchor, we all know they work very well. They're widely used. There is some anchor burden because they tend to be larger than your all suture anchor. And you can see some osteolysis. And in this study from 2019, we see those at risk for postage stamp glenoid fracture are those who are male under the age of 25 using more than 3 anchors, solid anchors. There's a little bit more osteolysis there. So again, to watch out for that. So in my practice, I moved to all suture anchors. Certainly, these are continuing to be innovated over time. Again, loss of or less risk of the bone loss that you have. Revision cases, you can use them. You can get around old anchors that are there. You can use more points of fixation because the drill is very small. There are similar biomechanics when you look at the literature and compare the two. The thing that has been really nice for me is really using that curved guide that has been innovated so you can get very low on the glenoid without going through your subscapularis. And I tend to use these a lot posteriorly. I think that's really helpful. So as we look at knotted versus knotless, how many still, if they do shoulder surgery, still tie knots? Yeah, so a good number are still tie knots, and I think I think that using a knotted suture is a great it is great biomechanically, works well. There are some issues with it. So the knotted knots can cause abrasion. You can get loosening of your knot depending on how you tie. The surgeon variability, of course, but the thing I like about knotted too is that I can adjust the tension of the knot before I cinch it totally down. So you have some reprieve if you find you've retightened it or it's too loose. I have moved to knotless suture anchors, mostly in the posterior, but still use them anteriorly in my instability. Again, they can be more efficient. There is a lot of suture management going on, so you have to be careful of that. They are more expensive. Again, some people say there's an earlier learning curve. I'm not quite sure about that. But again, once you tighten them down, there's no adjustment, so you have to be really careful about your tensioning of the anchor. If we look at the studies on biomechanics of them, again, biomechanics for a knotless versus knotted anchor are pretty similar in the literature there. If you look at other literature here, again, we're comparing the knotted versus a knotless. The more recent study in 2024, again, really showed no clear clinical difference as well. So you're looking at biomechanical and clinical differences are about the same. So we had 720 patients. Really, the dislocation, subluxation rates were about the same, patient outcomes the same, and revision surgery about the same. So in reality, I think surgeon preference is the way to go here. If you like tying knots, I think that's important. If you work with other people where you're teaching or have residents, teaching them to tie knots is really important. But there may be times where you want to use a knotless anchor. Moving on to rotator cuff, again, a lot of areas that we've seen innovation, types of sutures, augmentation of our repair, which I'll focus on, and then a little bit about the balloon spacer there. So again, we've seen advances and innovations in the type of sutures we use from our standard Ethibond sutures to now more polyblend sutures, even sutures that have absorbable inner cores, as well as cores that might react to the saline that's there and change over time. Even wider sutures, such as the suture tape seen here. There are other sutures, I'm sure, coming down the pike that you may see that are adjustable, or you can tension or measure the tension on. So we're looking forward to those as well. When you look at augmentation, the rotator cuff repair, as we know, our goals are to improve the healing because we have high failure rates, to prevent the re-tear from happening, and really to provide that mechanical strength because we want to increase that load to failure of our rotator cuff repairs and provide a framework for cellular growth as we look at the ways we can augment the rotator cuff. So indications for me, really, if I look at a patient who has poor tendon quality, really a high degree of fatty infiltration, so make sure that you look at that. A borderline repairability, can you get that cuff all the way back to where you need to repair it to? Someone at advanced age, maybe over 70, you can use that as a cutoff as well. And revision surgery in many cases, think about augmentation. And then certainly there's some evidence that augmentation can help partial thickness tears as well if you're going to operate on them. So let's start with biological augmentation. You heard a lot about that. Again, the most studied in the shoulder and shoulder surgery is really PRP, or platelet-rich plasma. Again, the concentration of growth factors are listed there. The early studies, really showed no difference in clinical or no clinical benefit. But there was some evidence that maybe they helped re-tears where they were small or medium size. But as you look at the literature now, and this is a nice meta-analysis, 1,800 patients, use of PRP and rotator cuff repair, really saw decrease in re-tears. So we're seeing a little bit better evidence of this. And again, increased functional outcomes and decreased short-term pain. So again, something that you could use to help your repairs. Other things that were mentioned, particularly in our last talk, were the mesenchymal stem cells and cytokines. Again, as was earlier stated, we're seeing a lot of really positive results in rat studies, but really hasn't translated to human studies as of yet. But again, good potential there. And then just hot off the press, the autologous dermal fibroblast. This is a study from 2025, really using 86 patients. It was prospective, randomized, so again, we rarely have those in orthopedics, but we saw that the group with the fibroblast really had a 5.6% re-tear rate, where the controls was about 24%. So again, I think you're going to see a lot more of the biologics coming down for treatment of rotator cuff tears. So this is a patient of mine, 83-year-old, active, had a previous rotator cuff repair. You can see there the metal anchor, so it was a while ago. Pain with overhead activity, and at night you can see the MRI shows a retracted rotator cuff tear, not retracted all the way to the glenoid, so that's at least a positive for us. And again, you can also see the atrophy of the supraspinatus and the fatty infiltration. So what am I thinking about in this patient? So I'm thinking about, okay, how can I augment this, not only with biologics, but perhaps with a graft? And here are a list of the grafts that are currently available or commonly used. The xenografts, porcine submucosal graft, that was used in the past, but really caused a lot of inflammatory reaction in patients. So again, sort of fallen by the wayside. I think most common is the porcine dermal graft or allograft or dermal allografts. Synthetics have also been used and actually show some good results, and there's some examples there. And again, your autograft, so using your biceps, if you're going to do a biceps tenodesis, taking that end of the biceps and flattening it out and using it as an augment has shown some success as well. So here's that same patient. You can see the rotator cuff tear and the type of rotator cuff I had there. I was able to bring it back all the way to the humeral head, so in a double row configuration, so as you can see there. And so I chose to use an augment of a graft. This is, and again, you can choose. There are multiple companies who make the graft. This is the one I chose for this patient. You can see it's inserted in sort of a tube and then spread out by these prongs over your rotator cuff there. And then you can secure this graft with a staple. And this is a bioabsorbable staple that goes in again through a tube onto your graft. And then you can see sort of the final construct on your far right, and then that will absorb. Some of these grafts are bioinductive, some are dermal allografts here, but you get a nice covering of the rotator cuff. There are bone staples as well, so you can also attach it down to the bone if you choose to do that. So what do we see in the literature? Again, a lot of meta-analysis regarding augmentation and the uses of patches. Really is all these, some recent ones in 2024, showing in all comers, all types of augmentation of grafts, so not one particular one except for the one at the bottom. They demonstrate really lower re-tear rates and higher ASES scores with the augmentation. So again, we're seeing really good, nice reports and outcomes for these types of surgeries. And just finally, on the balloon spacer, most of you might have heard about this. Again, this is used for massive rotator cuff tear, so if you have a massive rotator cuff tear, you can use this. It also can be used as an augmentation too, so if you have a rotator cuff tear that you feel that you need more space there, you can also place this. It is biodegradable. It takes about 12 months for it to degrade. It's inserted and inflated with sterile saline during the procedure. And really the literature, again, has been pretty good on it. Again, when you look, this is a meta-analysis from 2023, JSES, and it looks at 17 studies, so people are really looking at this. A lot of shoulders. Again, the patients report good outcomes, but there is a 3.6% complication rate, and that's mostly migration, so it moves out of place. But there's a 5% salvage rate to reverse total shoulder. So these are the patients that you would be considering this in, someone you might consider a reverse total shoulder in. So in summary, I think innovation and advance continues to lead us to better treatments for our patients. I think you're going to see a lot more AI, as you saw in the meeting today. Several of us speakers mentioned it. And again, use of biologics and augmentation in shoulder surgery, I think is going to continue to increase, and you'll see a lot more of that in the future. Thank you.
Thank you for those presentations. I think we have time for questions. Okay. 2 microphones if anyone has questions. Otherwise, I might jump in. Oh, here we go.
Hi, thank you for the talk. I have a question for Dr. Haim for her knotless use of the glenoid anchors for the instability. So I switched over to Arthrex and used their knotless system, but my question is, are you using like a simple suture, just pass it and tie it and cinch it down, or are you using like a horizontal mattress? Because I feel like horizontal mattress looks better on the pictures when I show it to the patient, but then I feel like it actually had a higher failure rate with horizontal mattress. So I'm just curious what like configuration you use for your knotless anchors. Thank you.
Is it on? Is it on? Yeah, okay. Yeah, so I use a simple configuration, but I agree with you, like the way it looks. Because even if I look at my knotted versus knotless, I feel like the knotted actually looks better, because when you're using that horizontal mattress, it just brings up that bumper a little bit. But I'm certainly not having any, and I don't really do the horizontal, so I can't compare those two. I don't know if anyone else in the panel does that, but yeah, I think simple is fine and adequate.
Hey guys, thank you. I have a question for Dr. Koenig. So I'm a joint replacement surgeon, and unfortunately and somehow I get high school athletes come into my clinic, and so I quickly tell them they're in the wrong place. But then usually the scenario is they have an ACL tear, they need an ACL reconstruction, at least what I think. 17 years old may or may not want to play college athletics. Should I be telling those patients, hey, like a repair may be an option, or just can you walk me through, like, what's your conversation with the 17-year-old who may or may not go to college for athletics?
So I'll give you a perfect example. I had a rising senior in high school, football player, tear his ACL, bucket his meniscus. He is hopefully getting recruited to play college football. And this is springtime that this happens. And he knows that if he gets an ACL reconstruction, he's not playing this fall. But he had heard about ACL repair. He had gotten 4 or 5 opinions, as most West Side families do. And they came to me saying, we know the literature. We've spoken to enough doctors. Like, tell us what you think. And this is the conversation that I had, which is, your bucket needs surgery, obviously, and you need that now. And if you are open to the idea, we can attempt an ACL repair at the time of your bucketed meniscus, and that will give you a chance to make it back in hopefully 6 months by the fall to play your senior season. And it worked. And so, like, you have enough stories like that, even though there's overwhelming data that would suggest this higher risk population is going to fail. But it's a conversation, and you say the data. I mean, the number of times I've kind of said, like, higher failure rate, but if it works, it's pretty awesome. And it's like one of these conversations, and you let families decide. Often my hands are kind of tied in the sense that I'll talk to them about a repair, or they say they want a repair, and I will let them know, I'm putting reconstruction on your consent. It is possible that you will wake up, and because they're kids, it's always autograph, like, you will wake up with a much bigger surgery and a much more painful knee than you're anticipating. And like I said, I will try the repair, I'll put sutures in it, and I will pull as hard as I can in the operating room. And if those sutures start to pull or rip or start to come out of the stump, then I'll just convert to reconstruction there. So I think it's just a conversation. I do think, we will continue to get better and refine who I think is a better patient for it. But currently, it's one of the tools we have, and who knows if the Bayer implant is going to make ACL repairs better. Here's one comment I have for Natasha as a question. So Bayer is this new product that's come out. Every study we have for Bayer compares it to the gold standard, which is ACL reconstruction. There is yet to be a study comparing Bayer ACL repairs to just primary ACL repairs. So we don't even know yet if the Bayer is going to change, just if you have enough ligament length that you can just do a primary ACL repair, and whether the bear is even necessary in that circumstance. They would argue that no, but it's better for those 2s and 3s, those kind of more closer to the mid-substance type tears. But yes, I think that's the answer to your question, I hope.
No, I'm glad on your presentation too, you talked about the idea of Bayer with augmentation, with that lateral extraarticular, augmentation, whether that's ALL or some ITBN tenodesis, because especially the ones that want this Bayer, the repair, are often these young patients, and their parents too, who have often had ACL reconstructions themselves and are not happy with their knees, they're saying you. So they're very much intrigued. They've done their research. And in the younger kids, there is that trend toward the higher ruptures for the repair. So augmenting it with, some other procedure would be helpful. What would you say percentage-wise in your practice that of ACL tears that end up going to the OR for repair, whether or not it's done, but getting indicated for repair?
Getting indicated for a possible repair is maybe 15, 20%, and then actually getting a repair is closer to 5%.
How about you guys? I'm not sure. Do you guys do ACL repair?
I don't do the ACL repair. I mean, I think for me too, I mean, I'm waiting to see what really the outcomes are. So it's great that people are doing them so that we can see later on and adopt it if I feel it's right. I think there are probably, a subset of patients who it really, really works on. I think for me, I have a hard time talking to a patient to say, this is a procedure that might work, and I might be able to do the one procedure that I know works after that procedure. I think it's a little bit, difficult for me to say that because I think the ACL reconstruction works really, really well. And especially, I might be curious because you said in your younger patients, but, the data shows that younger patients don't do as well. So do you do that? And I would say like the older patients, I would be inclined to, to do more repairs. So if you have your
Those are my
60-year-old who's, skiing and tears their ACL, repair might be a good, option for them as well in that population.
Definitely, and then that conversation is a little different. They come in to see you with a torn ACL straight from the mountain, and I say, well, with your ACL, there is a chance that we could do this acute repair, but you got to make a decision now. You got a month, right? Or you can go shop around, get 5 opinions, ask your friends, do prehab, and then 3 months later, decide that you want an ACL reconstruction. So that's also part of the conversation.
Yeah, I think the majority of patients I would treat with the ACL repair are the proximal avulsions, and now it feels like they are finding it out on the web and then coming to me and asking me about the repair. So I'll go over the scans with them, seeing if it is amenable, and pretty much everybody's consented for both the reconstruction, possible reconstruction.
What percentage would you say you end up doing repairs on?
Probably 5 to 10%.
Not a huge number.
Yeah.
But I think I'd make a comment too about, we were talking about LATs as well, and, it's just the comment about patients coming. I have plenty of patients who come in now and say, I want ACL and LAT. And you're like, okay, yeah, all right. So, yeah, so patients are very educated, about all this. So you better be prepared to talk to them about it as well.
Yes, that's definitely true. They definitely do a lot of their research here, especially here in LA. Dr. Parks, I have a question too in terms of, you were talking a lot about the biologic augmentations intra-op. Because I have a colleague who pretty much it's 100%, at least with PRP, is, all surgeries get augmented, whether it's ACL, meniscus. In terms of percentage of your patients that are going to the OR, whether it's BMAC, PRP, or other, what percentage are getting some biologic augmentation with their surgery?
Probably about 20%. It's still kind of low. Most of the insurance companies aren't covering it, so it's a discussion you have with the patient about the additional benefits, which are still being investigated, and if they want that. At the same time, in the workers' comp world, a lot of the insurance companies are approving PRP injections, so we are able to do more and more of those. But yeah, right now it's about the workers' comp patients that get it, if they approve it, and the private patients if they are willing to kind of
Can I ask a question in light of that? All I do is workers' comp UR. What is the difference between the old studies and the new studies? I was told that the concentration of platelets is higher and there's more accurate control of that in the newer studies. How am I able to get approval from my colleagues when they ask for a PRP for, in addition to a rotator cuff repair? I don't get that many requests for meniscal repair, but if you can also address that as well.
So
or
the
anybody up
question
there.
is, how do you get the approval, I guess? Well, when we are looking at the literature, there are more and more randomized controlled trials being investigated and published. I think right now there's maybe 5 total for rotator cuff repairs, but they're mainly the cellular augmentation. So it does take a lot of time speaking to the UR department, discussing this, any of the issues of the patient, any risk factors, including the diabetes or something that would increase the risk of revision. But yeah, I think also for the younger patients to help augment the repairs of the meniscus.
I think it's really hard to get it approved.
Yeah.
So, you,
Well, no, I'm
so
asking you to give me
patient-
some tools so the cases I review, I can approve.
To get it approved?
Yes.
Yeah, I
That's
mean,
my-
I think for me, we present all the information to the insurance company, and again, I've had patients have to pay for it on their own if they decide that they really want it. So there are a lot of times we don't use it because of the reasons you're talking about, is that insurance companies, especially the PRP, when you're looking at like an augmented graft, that's a little bit different. The hospital will has to approve that, and we've gone through value analysis and all those committees that you have to do, presenting the data and the newest data to get those approved.
Okay, maybe I'll ask you afterwards and maybe talk to you individually to help me help my peers.
For Dr. Haim, the 83-year-old with the recurrent rotator cuff tear, retracted tear, anterosuperior tear, that was begging for a reverse shoulder. How did you come to that decision, and how did she do?
So the patient really did not want a reverse, and this is the father of a colleague, who was very well, educated, and really refused the reverse total. And so, I told him I'd make every effort to repair it, and we were able to get it done. He's doing very well. Pain is down. Whether that's going to hold or not, I think time is going to tell on him.
Any other questions? Thank you.